All righty, let's get going. You ready, Annie?
Yeah, go for it.
Our cohort in crime is not here today, so we'll be managing the ship without her. We're going to be talking about navigating the lack of understanding of CoCM in your organizations. Um, and I see some of his eyebrows raise up. All righty. And then also this is just, I work as a turnkey sort of solution for COCM. So it's not just within your organization, but also organizations that you work with or partner with. So um, just wanted to kind of clarify that. And please, discussions are welcome. Daniela, nice to see you. But to start things off, if you guys could get your phones ready, there'll be a QR code coming up, and that will get you straight into a quick Menti. And let me share my screen and get started on it. All righty. Can just someone tell me that they see that?
Yep, that's good.
Excellent. So I'll let everybody kind of get ready. I just think we have three little quick questions to kind of get things going, get us on sort of aligned. All righty, here we go. So in one or two words, how does lack of understanding of COCM show up in your organizations or the ones you partner with? A little trend going on here.
Yeah. Mhm.
Well, I think I know what we're going to be talking about today. Annie, what do you think?
Yeah. Yeah.
No shared vision of model. That's part of what we were talking about in prep for this. I have to prescribe
Maybe the PCP perspective. Yeah. A little
billing understanding. All right, here we go. Next one. Who are the key Who are the key stakeholders where misunderstanding tends to occur? Leadership, human care docs, or providers, billing, patients? Legal. Some potential alignment with PCPs and referrals, I imagine. All righty, and then one last one. How does the lack of understanding affect day-to-day implementation? Pretty informed group here, Annie, huh? This is
Yeah.
what we were talking about. We were prepping for this.
Yeah. Lots of impacts for sure across the board.
Okay, you want to move on from here there, Andy?
Yeah, can you scroll down quick to see the bottom? There were more coming in. There we go. Yeah.
Lack of buy-in in everywhere.
Yeah. So yeah, we wanted to talk about this topic just because I think it's a chronic kind of thorn in for everyone, but it can look different across settings and organizations. But I think there is definitely some themes and things we can all kind of relate to. But so wanted to talk about both identifying what those interferences could be, but also so maybe starting with that and then definitely shifting the conversation towards what people have done to move past those roadblocks and hopefully gather ideas and inspiration from each other around how we could maybe things we haven't tried to navigate those difficult situations and troubleshoot and work our way through the challenges. So that was our the two kind of questions, but let's start with the first discussion questions around just identifying interferences. So I'm gonna put a few just discussion questions in the chat, but I will read them out first. So thinking about when is collaborative care misunderstood and what types of interferences have you observed? Um, and then how does the misunderstanding CoCM affect role clarity between care managers, primary care providers, and the psychiatric consultations? And let's start with those two for now. So what are you seeing? We saw definitely a heavy theme on referrals and appropriateness of referrals. And I think that is a very common pain point of any, especially newer implementations, but even uh, when there's change in an organization and maybe onboarding of new providers, or it definitely can shift again at different points in time. So does anyone want to talk a little bit about that specific interference that many of you were experiencing, or any of them, honestly, that were coming up?
I'm happy to share some previous experiences
Thank
with,
you.
hi, with referrals, or appropriate referrals. I think, and this is just from my experiences, um, when providers hear that, oh, a behavioral health program is coming in, they hear behavioral health, not COCM, and even if you share all the trainings and the slides that you want and share the triangle, they just assume that they know what it is. And they kind of see it of like, oh, anyone that has been crying or has expressed any signs of distress or crisis just goes to this behavioral health intervention instead of really clearly understanding what bucket of folks would best be suited for COCM. Um, on another note, I also, and this is just something I have more recently kind of discovered with my organization that I just joined recently. Primary care providers are so accustomed to prescribing or writing a script. So if you, Annie, present to me and they say, you have all this trauma, you need trauma therapy, and they're writing the script for trauma therapy, and they'll send that script. So when I call and say, hey, this is, Daniela, I'm going to be working with you, and the patient says, no, well, I don't need COCM, I need trauma therapy, or, very specific modalities, and then you're just stuck. It doesn't matter how wonderful the program is, you're not going to be able to satisfy
Meet the
that
expectations.
and meet those
That seed
expectations.
that was planted. Yeah, for
Exactly.
sure. I found that all the time when I was working as a BHCM, where patients would come and they had this description or something that was explained to them or interpreted by them of the PCP's message, and sometimes it didn't necessarily align with what we were doing, and so then there had to be kind of some readjusting, but also sometimes no description is also just as difficult because there's also expectations that can come from all over the place, their friends, their family, media. But yeah, that's definite. And then the first one you mentioned was kind of that one size fits all. So anyone experiencing anything getting referred. So yeah, that's definitely happens. Anyone else want to share? Thank you, Daniela. Jen, you're smirking. I feel like you have
Yeah,
something.
I always have plenty to say. Yes, it's a game of telephone, right? Because even a
Yeah.
PCP with good intentions of, okay, I get the model, I'll go and talk about it. It might be a couple weeks before they get a chance to practice the elevator pitch. So they just remember things like triangle, behavioral health, psych, counseling. And so what they spit out at the patient
Yeah,
sometimes is second, third, or fourth removed from a good, strong fidelity explanation. My
yeah,
best advice is radical acceptance. This is tough. You're going to have to teach, reteach, talk about the triangle, talk about what it is and isn't all the time. Accept that. Get
yeah.
excited about it. This is your effort in changing culture, and culture changes hard and it's slow and you won't notice it at this level. You have to zoom out and take a 10-year view of where you started and where you get. So just keep going because, you, what else
I
are you
love that.
what else are you gonna do? You're gonna quit and not do collaboration? No, you're not. You care about your patients. You're gonna keep
Yeah.
doing the messy work. So
Yes. And I like how you state also just trying to see the progress, even though it's maybe not the pace that you would like. It honestly rarely is in healthcare. So just radical acceptance. I think that is a great kind of the part two of the discussion around what can we do to navigate that. And that is probably part of it. There are things we aren't necessarily going to change. And you think of all the referrals PCPs have to make, and the different rationales and referral criteria for everything, that it's one in I don't know how many that they have to remember a service that they could consider for this patient in front of them. And so it's gonna take some repeating to get people.
yep. And I didn't mean to be all glass half empty. Keep coming to
Mhm.
these meetings because I think that's where you get or it's like where I did, the umph to keep going. You find folks that are like, hey, I too have this challenge. Because I don't know about you guys, but at first I was like, I'm gonna suck at leading this because they don't get it. Despite my they're not understanding. Maybe I should just quit and go back to regular primary care. But that means you're onto something. If you find that this is hard, it is hard. It's supposed to be hard. It is messy, but CFHA, I hope, is that place and your friends here in the Zooms or the meetings where you're like, okay, little refill the cup of keep doing this, don't quit. So
Yeah. You love it. Any other interferences and then approaches or tips for navigating that people have?
I wanted to jump in. I think one word that you said, Andy, was patient perceptions, right? So we're battling that. It's almost like the media has told everybody that it's a 45-minute hour for once a week, and it's going to go on forever and ever and ever.
Yeah.
We have patients say, I want long-term therapy. I'm like, okay, well, we might be able to get you there, but we're not going to be doing that. And so having that provider, I think we're kind of talking about it, but having that provider really set that tone. But then, we all talked about scripts, um, but giving scripts that are like hidden in special ways. Like I gave scripts to doctors in the patient handout about the program, and it really wasn't for the patient. We did all this sort of consent and all that stuff. It was for the script that the doctor saw right in front of him every single time.
Mhm. Yeah, I like that. Or put it into the referral smart phrase, like having it built in, even just the talking points, so they can still use their own words and um, have it more casual. But yeah, I like that idea.
Any other pain points on this?
I don't have a pain point, but I do have not a remedy, but it's what I do when we have new people come on board is I started doing this maybe 3 years ago, I think, because we have a really big practice. We have 24 providers. I'm the only therapist in this practice right now. And so whenever we'd have a provider that would leave, and then we obviously are hiring, I'm in an OB office, just to clarify. And so one of the things I started doing a few years ago was like not really mandating, but like talking to my CA, my clinic administrator, about making sure that I get 15 minutes of FaceTime with, and I'm remote, so I'm not actually in the office. So that's another kind of disadvantage to my position. Even though the advantages are greater for the patients, it's a disadvantage for the providers. Not seeing me all the time. They know that I'm there, but with the new people, whether it's a MD or a nurse practitioner or whatever, I kind of request like nicely, like 15 minutes of FaceTime on a Zoom call or a Teams meeting just to introduce myself so they know who I am. So I get a feel for their personality. So I know kind of how to interact with them because every provider is different, to get a sense of their buy-in with what we're doing and do they understand and are you willing to send off your patients for some mental health support, that kind of thing. And that has been really helpful across the board. Like I think I've done 5 in the last 4 months because we had 4 people that started in October and then we had 1 new person the beginning of this year. So I just kind of make it a point to let them know that I'm here and that they're, absolutely can ask questions. And my kind of default is if you're not sure if the referral is appropriate, send it to me anyway, and then I will figure out how to help this person and navigate them to where they need to be if they're not appropriate for the way that we're doing things in the clinic. So that has been helpful. So they don't feel like there's that burden there of like, who do I send this person to? They can send them to me anyway, and then I have a pretty good, way of kind of managing that here network of therapists that I can reach out to and say, hey, I've got this patient that needs X, Y, and Z, who can manage them and then kind of send them in that direction. So that's kind of my thing that I started doing on my own because I just felt like I would get these referrals from these providers and I'm like, who is this person? Like I don't know who this provider is because I wasn't made aware that we had a new person that was coming. And in the past we have had issues with I work for a big hospital, so other offices knowing that I'm available or that I do this service, and so they will try to send them to me, and I'm specific to my office, and so I'd have other doctors sending patients to me that were not seeing one of our OB providers, and so in order to kind of like streamline that a little bit, that was something that I kind of needed to do, so I knew who was on our team when they showed up, and so that's been really helpful.
Yeah, I love that. And just as an opportunity to also kind of hear about where they are, where they came from, and what, maybe they have a lot of comfort around prescribing psychotropic meds and working with patients who have behavioral health needs. Maybe this is all brand new and they've never, so being able to first ask kind of, what do you know? And then let me explain how our program works and how it can align with like your existing skill sets and just assessing buy-in that way. I love that because I think it can be, a two-way conversation versus just here's the like handout or workflow on what this is. Yeah, where they're at, what level of buy-in do they have, any extra kind of support they might need. Like I know when we onboarded providers that were straight out of residency, like I would meet with them and provide a bit more of a robust description, but maybe then also I would relay that to our consulting psychiatrist who is external and maybe didn't know that. So let's give more of a description around titrations and just know that it's like probably a little bit of a bigger curve, learning curve as far as, prescribing this class of medications and things like that. So yeah, I think that just getting to know them a bit in addition to them getting to know the programs. I love that bilateral connection that you're making.
Yeah. I think, Annie, you taught me a phrase of you can always do a dose of collaborative care. I think you I don't know, I stole that from somebody, but that's helped me because PCPs sometimes get stuck on that where it's like, this doesn't mean it's the be all end all. This is not the end state of their care, but it doesn't, by saying a dose, you don't turn off PCPs because Gretchen, I love your point of, if you're not sure, send them to me. That is key because what the PCPs will do so fast if you send them back, not appropriate, nope, can't help you. That really turns off PCPs to something that could be really good and helpful. So even just having that open stance of like, sure, send them to me. We'll see together whether this is the right fit for them. PCPs love that because otherwise they're alone. If it's just it's just PCP figures out, oh, what do I do with this person? With you, I'll at least see them once and together and we'll loop in the psychiatrist. Hey, this person really needs a higher level of care. Let's loop them into specialty. that goes so far with folks that you can bridge. I think sometimes the bridging sometimes feels like a bridge to nowhere. That's a whole other conversation. But at least from the get-go, you get PCP's engagement around this is the group of us figuring out what this patient needs and the next right place for them to go. And you will get PCP's buy-in if they feel like they have a real team member in you. So good job, Gretchen. That takes guts and courage to like, oh, it's not appropriate or is appropriate. I think anything you can do to just build those, I'm in it with you. It's not just you. There's a we, right? They appreciate the we. So
Another aspect to that is if they get sent to me and they're not appropriate, it's having that conversation with the patient as well, so they understand that my job is to make sure that they get somewhere where they're going to get the best care. Even though I'd love to try to help, it doesn't make sense when they can get better support elsewhere. And so again, within that conversation is explaining how we have a shorter term, more streamlined model than your typical psychotherapy. And so that helps them understand why I'm not taking them on, even though I would love to help them. It's just not the best fit long term. And so that's helpful. And then I'm going to give them some support. Like, I'm not just going to send you out there to the wolves. Like, I'm going to find somebody that might be appropriate and then connect you. So that's helpful on that end too.
You know what?
And you're still their, primary care home. So they're still going to need to, they're still connected to you and the provider and that team, even when they're sent out to, so even having a point of contact where if, those services end or they need some, this is still their home and you need to so I definitely like the bridge approach. I don't think all organizations can offer that, and that's fine, but I do think it does provide this is your home and you can, check in with us, and you will be checking in with us over your lifetime, but we're gonna, may or may not be providing the services here at different points, kind of depending on what's happening. But you can still be a point of contact.
You know what just occurred to me is the title of most of these roles are behavioral health care management, and my thought is do you think the providers forget about the care management side of it?
Mm-hmm. I do.
Yeah,
yeah.
it's we're representing a real quick, easy access solution for them for behavioral health issues, but also SDOH issues, also access to care issues, things of that nature.
And med management too. I would find in training PCPs, oh, I can handle the med management. I've been doing that forever. That's fine. I'll keep doing that. I'm just going to send the patients that need behavioral interventions. But there is so much strong evidence around the benefits of the care management, even when patients don't have behavioral interventions in their treatment plan and they're just taking meds, that additional support that's provided and increased kind of adherence and actual medication trials. It's so helpful. But yes, and everything else you mentioned with the all of the pieces of care management and tracking. And so yeah, it's so helpful, but I don't think there's always an understanding of the kind of menu of services as well, and the benefits beyond just the behavioral interventions.
I can really identify with that as well, because I think with that role and title for that position, there's been a lot of opportunity for education around what all that can encompass, and also how there is still a lot of value in the clinical interventions provided. Some PCPs have said, well, if my patient can't get the same therapy that they would get in specialty care, then I don't know that I want that for my patient. So how are we providing that education, and balancing? I've thought in the past, is this the right title for this role? And yet I've wanted to have fidelity to the model. But that's a challenge that's come up for us, especially with peds.
Mm-hmm. Well, when I'm doing implementations with different organizations, I always say you can call it whatever you want. Honestly, that doesn't make or break fidelity to the model. So if you feel like it doesn't fit, I think there's several terms in collaborative care that are kind of more model aligned, but that aren't maybe the best or not for your population or your organization. I think that's totally fine. There's pieces that are, required for model fidelity, but that definitely you can change it. Relapse prevention planning, I don't love that term. we use it because it's in a lot of the literature, and but I don't think it's necessarily the best. So I love asking people their alternatives to those types of interventions. And so yeah, if people feel inspired to change the title of that position, feel free.
Any other suggestions, concerns, comments?
Another one that looked like it came up fairly frequently, not as much as inappropriate for referrals, but was billing issues, understanding billing. Yeah. On the billing side, does anyone want to share any kind of pain points or interferences and how you've addressed that?
I don't know if I can offer how we addressed it,
Hi, Christina.
but we have had a lot of trouble with billing and communication. And part of it is because we're switching, or we have switched, I guess, ownership or the company or whatever. And so a lot of the processes, the workflows for when we as the collaborative care managers are fine to do our billing, and I think we have a pretty good workflow for that. So we do the billing and it's all within Epic and all of that. But then on the receiving end, when the coders get it, a lot of them are untrained on what this is. They see us as the billing provider, which then ends up causing some confusion with the insurance companies. We also have had patients call their insurance companies and the representatives there are giving them bad information saying, you know, if this is because we've also been telling patients, please tell them this would be, these codes would be billed under the primary care provider. And then the insurance representative will tell our patient, well, that primary care provider needs to be a licensed therapist because it's a behavioral health code. And there, we don't have the bandwidth to do all of that for the patients. And so there's a lot of messiness in that. One thing though that we're hoping to do soon is to just at least have some dedicated people in the billing department who understand what the collaborative care codes are, who they should be billed to, you know, what to, I mean, I feel pretty confident in the team and how they do their billing. But yeah, still like, you know, catching maybe they should have done a subsequent month or they should have done a first month because they haven't done a first month billing yet or something like that. So it feels really messy and it feels like there, I don't know how far the misinformation reaches, so I can't catch it. So that's something that we're struggling with as a program.
Yeah. Yeah, I appreciate that. I guarantee you're not alone. Anyone have any relating to what Christina said or any ideas of how they've approached it? Definitely a challenge.
I mean, in New York State, we really encourage and kind of require that there's a billing or finance person that's part of the implementation team, and we try to get them on board as soon as possible in the initial like workflow development and implementation conversations, so that the building of whatever that workflow is for claim submission is kind of done together with the clinical workflow, because sometimes there's like issues in documentation or how the minutes are going to be captured and how that's translated, and you know, a big division between the clinical program understanding and the billing understanding of how collaborative care works. So we try to bridge that gap early on, and it still doesn't fix everything. But I think that has helped a lot to just make sure that everyone's kind of speaking the same language and like part of the conversation early on. But you know, we provide a lot of technical assistance, and I feel like the vast majority of it, like 50 to 60% of the support we provide is around billing to sites directly. So
I can imagine.
it's always work.
But yeah, I love that idea of bringing people on, bringing people from that billing and finance team, including them earlier on. So there is this understanding. I just sent an email yesterday basically explaining collaborative care because there was this confusion on why we would use certain codes for, yeah, what if they need more than the 4 allotted add-on? Like it was like, then that's probably not a person for collaborative care, but they just not having the base knowledge, it creates so many additional questions and it, yeah. So I love that idea, and it doesn't mean there won't be challenges, but I think it can help mitigate and smooth things, the process as much as possible. Thanks, Amy.
Bernie, you want to speak to what you just put in the chat?
Sure. I mean, I and Amy kind of just talked to it a little bit, like right from the start, getting finance folks, senior leadership, and doing a pro forma. So what is the financing going to look like? What is revenue going to look like? What is reimbursement going to look like? At what point? How many patients are you self-sustaining? What is a full caseload meet in terms of margin? And then revisiting it, 60 days in, like, did we get it right? Is our reimbursement looking like what we thought? And really working on it. And if you follow that sort of 30, 60, 90, most practices we're finding, I mean, depending on like FQHC's large uninsured rates are, self-sustaining between 58 and 64 patients. And so, but then they know that, like, obviously not a full caseload, but then they know that, and it's good information for people to have right up front. Or maybe the state doesn't cover Medicaid and you got to figure something else out, and where can we get reimbursement and what other codes do we have to use? But now, with the majority of the states having the codes, you can just do a collaborative care pro forma up front.
Yeah, I love that.
I just wanted to jump in and honestly, I'd echo everything Amy and Verna both just said. I think it's really valuable to pull in billing as soon as possible, very early stages, build that pro forma, build goals around the caseload and, have accountability spaces to review how you're progressing and troubleshoot that really proactively, build a sense of urgency there as well. I think ongoing touch points is really important. And then also some cross kind of workforce work as well, not just having the billing folks just in billing meetings, but also having them in clinical spaces and IT build spaces. Because realistically, it's all going to touch each other and you're going to need their input, and it's just going to slow things down if you have to send emails up and down the chain, and then you're going to have to build those explanations in as well, build additional spaces. It's not realistic to have the full billing team attend every clinical meeting, but you can, flag the ones where it'd be valuable for them to attend or flag a person to attend the majority, with, of course, that clinical team being the primary attendees. But I think it's really valuable to have them involved because they have to understand the model to be able to understand why we bill it the way that we do and why the panel size is so important and why we talk about all the things that we do. And they also need to be really involved with the IT build. There's a lot of input that they're going to need, and they also need to understand how to pull that information from the system. So,
Yeah. Yes. Thank you, Nicole.
I've often thought that billing is often seen like the de facto compliance, last line of compliance. So I think that's kind of what you're talking about, Nicole, where if they don't understand it, they're not going to bill it, and then you're got some troubles.
Mm-hmm. It also puts it on their radar because a lot of times, particularly if you're slow, implementation, they're like, well, I'm not going to worry about that. It's only 10 patients or, and then you don't get revenue, but you also don't understand problems with processes or reimbursement in time.
Yes. Any other thoughts on this particular pain point or kind of interference or others that people are experiencing frequently that they want to bring to the group and can have a discussion around navigating those?
Any comments about, pulling in leadership and more substantial, and their time is very difficult. There's a lot of expense to it, but their understanding is super, super important. And then reporting back. I'll share a quick little story for myself. I actually used LinkedIn to advertise my program. And so use LinkedIn to kind of show the positives and stuff like that. And our leadership were on the LinkedIn, so they were getting regular reports of how well their program was going, but then also other people's comments on it.
Yeah, sneaky. I like it.
All righty.
I do love the idea of kind of getting their attention from different places, just because I think the email can be a place where sometimes communication can go to die, depending on who you're emailing. So I think also just knowing who you need to communicate with, who's the transformation team, and at what point to pull them in and how frequently, and kind of just helping them again to understand the value of their participation. You need folks that can, make decisions for the system, that can, allocate funds and funding. And you won't be able to get very far if you don't have those folks in the room every once in a while. Um, I do have a pretty basic like transformation team worksheet that I can throw in the chat
That would
that
be
talks
awesome.
about some of those stakeholders.
Yeah, that would be great. Thank you.
Yeah.
How about like role clarity? Do you feel like that's been a regular occurring challenge, or is that less frequent?
I can kind of pop in here a little bit. I think it can be. Sometimes because, like I mentioned, sometimes it's helpful to have folks in multiple spaces and that can get a little confusing. Sometimes building like a RACI chart or something like that, or some kind of org chart that helps folks to understand where they're supposed to be and what their role and purpose is can be really valuable. Very early days too, like pulling like a list of what stakeholders you need together and having their contact, their email, like all of that lined up so that if you're not getting a response through one avenue, you could get a response or another. Like, are things that I feel like I've learned those lessons the hard way around that can be really nice to have.
Yeah, thanks. I like it. I know on the poll, the question around, key stakeholders misunderstanding, where are you seeing that? And so I saw a lot of PCPs, patients, billing, PCP, patients, billing, PCP, and one at the very bottom said BHCM of that poll. And I just wanted to comment on that one in particular as someone who directed a program and oversaw quite a few behavioral health care managers. I thought that was the hardest group of people to fully understand. It kind of depended. It really depended on their background and their experience and where they were coming from. But it was tough. I mean, that transition for behavioral health care managers, depending on their education, their background, what work experiences they've had, their comfort zones. Like I thought that was quite challenging, and could take quite a bit of time, even up to like a couple of years for people to be really functioning as the collaborative care as that role is meant to function. So I don't know if others experience that challenge, but definitely, as folks coming from like doing more long-term traditional psychotherapy private practice for a couple decades, like it was a tough transition and not necessarily for a good fit for everyone, but definitely one approach that we took was just really rewriting, doing a big overhaul on our job description, and then having lots of conversations about what the role was during the interview, asking, how many patients people have seen in a day, typically would see in a day. And if it's like 4, then like really needing to give them a reality check on what this is and are they still interested. And it's very, very different. And yeah, it isn't for everyone. And so that's also the truth of the matter, and but trying to support those who do want to make that transition and provide the supports that they need. But I found that really challenging.
Proactive rather than,
Yeah.
passive.
Yeah.
Verna, you wanted to do, I just want to make sure you knew we'd save some time. We're going to save some time. You had some announcements you wanted to do.
Yeah, Gian is on with me. And we just wanted to share with folks an update on the national work groups and also a national outcomes and research project we're kicking off for collaborative care. So Gian, I think she's able to share some slides. She's always right on it. Just really quickly, and thank you for the couple of minutes, really appreciate it. We have started in conjunction with Meadows last year now, Nicole, I want to say maybe a little bit longer than that. Time flies when you're having fun. And it actually started with the pediatric collaborative care pathway, which many of you have seen go out, and quite a few CFHA members were on it. Jill, Cody, as some folks from Meadows, Concert, and from around the country got together and basically decided to solve a problem in the 6 to 11 collaborative care space and wanted to create something that was very practical. So did a whole process of looking at all of the tools, ranking them, putting in some resource documents for practices, putting out a pathway, and created that. And again, this was all out of everybody's own time. It was not reimbursed or subsidized in any way, although hopefully that's going to be something that's going to change in the coming year. The pediatric pathway was shared on the CFHA listserv. It was shared with this group. It's been updated. It was presented on last year. And so stay tuned for that again this year. And because that was so successful, we actually expanded and developed other ones. So we have early childhood, which Jill is from Mira is actually leading. She is very passionate about that population. Women's health, older adults, and SUD, and also probably going to be people have asked about an ADHD one for children and for adults. And so these work groups meet every month. They are developing pathways that will look very similar to the pediatric one. These are people from around the country who are documented experts in the field. They have published multiple research articles. They have been active in the field. They're actively practicing in the field. And I wanted to just let people know if you or someone on your team is interested in participating, then please let me know and reach out to us. We recently were able to get some folks who were part of the creation of the BAM to actually join our SUD group and weigh in there. So that was a pretty good win recently. So stay tuned. As these pathways get developed, we will actively share them out on the CFHA listserv. We love the feedback and also want it to help and support the work that all of you are doing. And then this actually led to the bigger project, which is a national research work group. So if you are doing research in collaborative care, please let us know. We would be very excited to have you join. And what we are doing now is we are embarking on a rather ambitious project to essentially get organizations to sign on to share their outcomes. And we are going to do one large paper publication sort of to be determined around outcomes for collaborative care. And we are looking at these tools in terms of outcome measures. And so just want to, this is subject to some discussion, but these are the tools that we're actively going to be asking organizations about. We're going to be asking whether or not you collect outcome data on these measures, and if so, what outcomes do you collect? Go ahead. And then what we're going to be doing is we're going to be taking all of that information, and all of the organizations who have common outcome measure collections will be grouped together, and will report outcomes collectively across the board. Organizations who don't measure outcomes consistent with maybe other organizations, we will still report on your outcomes, but they actually will be separated out. So we're going to group as many as we can, and then report out individually for one sort of collective paper, and essentially to really report on the positive outcomes that we're seeing in collaborative care across the board. And this will be across, millions of patients. We have some pretty large organizations that have signed on, that care for thousands of patients in collaborative care, and are reporting since they have started providing collaborative care. So what we would like to do is we wanted to let all of you know about this. There is a data sharing sort of sign-on agreement that we can put in the chat, that you can review, that you can share with your organization. And if you're interested, this project is actually being run by partners of many of us, Ames and Meadows and Concert and others, JG Research out of Montana. And they will be collecting the data use agreements. They will be getting the data, doing the analysis, and working with all of the organizations. I think now we have about 14 organizations signed on, but essentially we would love to have everyone doing collaborative care. And so glad to answer any questions. And then I have one more research update, and then I am done. Everybody's so excited about this. I can tell.
So people would reach out to you if they wanted to be part of these.
Mm-hmm. Yeah. Yeah, this is really a big it's a big project, and I think it's a tremendous opportunity for advocacy and to really show collectively all of the wonderful outcomes we're seeing across collaborative care. And I think that's going to be really exciting. And just as not an exact comparison, but last year we put out a brief with the Bowman Foundation on suicide and collaborative care. And it was Concert, it was Kaiser, and it was Pennsylvania. And we all track outcomes differently, but they were all together in one brief, like here's the outcomes. And so something a little bit similar, combine where we can and not. Gian did just put the link in the chat. If you're not able to get it out of the chat, then we can, she just put the suicide paper in there as an example. Boy, she is so efficient. And so, please reach out and let us know. And then lastly, we are working with the Ames Center and JG Research on a new scoping review of all of the collaborative care research. As many of you know, there was something called the Cochrane Review, which happened quite a few years ago. We decided not to do a new Cochrane Review because that's only randomized control trials, and a lot of the work is not in a randomized control trial. And so Dr. Ratcliffe from the Ames Center, JG, and several of us are working on a scoping review, which will basically take all of the collaborative care research and put it in one place. And so we're really excited. That project is a massive project, and I think we've had about 12 or 13 students working on it in addition to staff across the board. So we can look forward to that at some point this year as well. But glad to answer any questions.
Thank you, Verna. I wanted to just put out another plug for our directory survey. We provided this link. I just put it in the chat. We provided this link last month. if there's any folks that weren't on the call last month who did not enter their information, you'll be able to enter information in the future, but just wanting to, as new people join our group, of course, but yeah, wanting to make sure we get the most that we can, and then we'll provide access to that directory in the near future. The other announcement was, and correct me if I'm wrong, Hannah, but we are canceling next month, correct? Because of the conference, the CFHA virtual spring conference overlaps with our monthly meeting. So I
Yes,
believe
that's correct. I'm
communication.
sorry, I haven't
on that.
updated the calendars yet,
Oh,
but
okay.
today you'll be getting a cancellation notification if you're already registered for that meeting. But we hope you can make it to the spring conference instead, which is May 6th and 7th. And then CoCM SIG will resume as scheduled in June and beyond.
Thank you. Yeah, thanks. Who's all going to the spring conference? All right, we'll report back. Great. I think those were the only announcements. Anything else, Ben, that you wanted to add? Otherwise, we can give some people transition time
Sounds good.
for your next meetings. Okay. Happy spring. Have a good rest of your day.
Great day.